Good afternoon, everyone. Dr. Tony Brown here with another edition of Clinical Pearls and Profit. So, welcome one, welcome all. Today, we will talk about the topic of asthma. Which labs do I order? Asthma, which labs do I order? So, let's go ahead and get started. First, I think it's instructive that we do just a little bit of work on what it is we're talking about when we say asthma. Now, you all will remember that with regards to respiratory diseases, there are restrictive diseases and there are obstructive diseases. Okay, so the restrictive disease is something that prevents your patient from inhaling. And then the other one's the other one. Obstructive disease is something that prevents your patient from exhaling. Okay, restrictive stops us from inhaling. Obstructive prevents us from exhaling. Now, the thing that allows us to inhale is something called compliance. In other words, if this is an alveolus in our lung, the degree to which it is easy to stretch this open is how we describe its compliance. Okay? If I had something very thin like this, like a kid's party balloon, it would probably be very easy to inhale air and push that open so it has lots of compliance. However, if I were trying to inflate something that was, let's say, this thick, like the typical water bottle that you might find in a hospital, okay, that is going to be very difficult for air pressure to push open and expand. We say that has decreased compliance, okay? Increased compliance with something thin, decreased compliance with something very thick. With regard to the lungs, why does something, why would something be difficult to expand? We say that it has a lot of elasticity, right? Elasticity. So when you think about asthma and this concept of elasticity, I want you to think about elasticity as a collapsing word, okay? Elasticity is your collapsing word. Compliance is your expanding word. Now, how does that all play into whether or not we consider asthma obstructive disease or restrictive disease? Well, you know what your patient looks like when they walk in the door in the middle of an asthma attack, right? They're using their accessory muscles, their inhalation goes really fast, and their exhalation takes a long time. It's kind of okay. Now, what I submit to you is that asthma is a little bit of both. In other words, the whole reason that they're having an asthma attack is because of bronchial constriction, right? Because the bronchioles are hyperactive and they've started to constrict. This means that you're going to have lots of problems breathing out. That makes it an obstructive component of asthma, a problem breathing out. Now, the strange thing about asthma is that it also has a restrictive component because with each breath, when they bring in air, it's very difficult for them to get all of the air out. That's why they spend so much time during the breathing cycle in exhalation. They're trying to get the air out of that constricted bronchial. Excuse me. So, but what this means is in the first breath, I'm going to make up some numbers. In the first breath, maybe they have 1 liter of air and they only blow out a half. In the second breath, they breathe in another liter, and they only blow out a half liter. So now they have a whole liter. In the third breath, they breathe in another liter, but they only blow out a half. So now they're up to a liter and a half. And this keeps going until what you have is this oxygen trapping in the lungs. And it's why the inhalation is so short. It's why it's because there's not very much room left in the lungs to fill with air because it's all trapped from getting out by the constricted bronchioles. What did we just say? Asthma has an obstructive component, excuse me, and a restrictive component. So the way that I'd like you guys to think about it when we think about labs to draw is to think about what it is that might be causing that asthma attack in the first place. Okay, well, there's exercise induced asthma. Okay, there's cold induced asthma. There is allergic asthma, right? So when you're deciding which labs, the first thing you want to do is to try to get some idea with regard to differential diagnosis of which type of etiology of asthma you're looking for. And kids suffer more commonly from certain etiologies than adults and vice versa. So you want to have a really good hold on that, right? So let's go ahead and look at, we're just going to walk right down the middle of the road and try to approach the type of asthma that will normally show up on these everyday labs that you would be drawing. So if you are a VirtualClinic subscriber, then you have access to both the Premier and the Platinum panels. And I forget the numbers on them. I can look a little later if anybody needs me to. Whatever it is, it's around 10 times the difference. Whatever the lab, the retail lab is that you're drawing, you're getting it for about 1/10, maybe 1/8 of the price. So if you need any more guidance on that, just shoot me an email or something. I'd be happy to help you out. Now, with regard to what exactly is on that lab panel, let's talk about taking an ABG. An ABG. So an ABG provides important information in acute asthma. This test may reveal dangerous levels of hypoxemia, hypercarbia secondary to hypoventilation. Typically, results are consistent with respiratory alkalosis. Okay, we just said a couple of things there. So how do you interpret your ABGs? How do you interpret your ABGs? When you get your ABGs, you're going to have a couple of numbers on there. Now, the way I typically do it, I have a protocol in my head for everything, right? I have a terrible memory. So the best thing I can do is do the same thing every time in the same order. So when you get them, you're going to have pH, percent hydrogen, right? We think about it as acid. You're also going to have your CO2, carbon dioxide, that is. And then you're also going to have your bicarb. Okay. Now, so with regard, I don't have these numbers memorized. I think the pH is 7.45. I'm sorry, 7.35 to 7.45. I think the CO2, I have to come back to that. I think the bicarb is 22 to 26, so that makes the CO2 35 to 45. All right, so let me just write them down here. You can check Dr. Google to see if I'm wrong out there, if those numbers look funny. Okay, I'm writing with my middle finger, so I won't write everything down. 35 to 45 on the CO2, 22 to 26 on the bicarb. Um, and the algorithm that I'm about to give you is not number dependent, it's concept dependent anyway. Okay, so your patient comes in, you do an ABG on them, you get these three numbers back. So you say to yourself, step one, I'm going to check the pH. And I want to know the condition of the blood. Is it acidotic or alkalotic? Is it too much acid or too much base? If it's below 7.35, then they're acidotic. If it's above 7.45, then they're alkalotic, right? And don't get mixed up in that old trap of thinking that more acid means a higher pH. pH is a surrogate of acid, but as you guys remember, the lower the pH, the more acid we have. It is percent hydrogen, but it's a reciprocal. It's 1 over a number. Okay, so high pH is base, low pH is lots of acid. So step one, you look at your pH. You figure, is there too much acid or too much base? Step two, you look at these other two labs and identify the one that is abnormal in the direction of your pH. Okay, what did I just say? So CO2 is an acid, bicarb's a base. So let's just say I looked at my pH and it was low, call it 7.2. Okay, let's just draw a line over here. If it was low, it showed up at 7.2. I say to myself, my pH is abnormal in the direction of acidosis. Now I'm going to look at one of these to figure out which one is in the same direction of acidosis. Let's pretend it's the CO2, I'm sorry. If my CO2 is increased, I have too much acid. How would that happen? Putting a pillow over someone's face, right? Not breathing, opioids suppressing the respiratory center, anything where they're not blowing off the CO2, which is causing it to build up in their blood. That's how you get high levels of the CO2. You're not breathing. So in this situation, let's say drug overdose. I've got a low acid, I've got a high CO2 level, so that's respiratory acidosis. It's caused by the lungs, and it's acidosis. Then you look at the remaining number. Here it's bicarb, and you see what it's doing. If a regular bicarb is 22 to 26, what you ought to notice in the acute phase is that the bicarb is going to start going up. So maybe it's trending high. Instead of right at 26, maybe it's bumping 25. So you should find your bicarb increased in this kind of situation because it is doing something that we call compensating. Oops, sorry, I was trying to make HCO3. Never mind, let's call it bicarb. Okay, let's do another one. Let's say your pH comes in and it is high. So now you've got too much base, too much base. So this is an alkalotic. If my pH is high, that's alkalotic. I look at these next two numbers and figure out which one is high in the direction of alkalosis. So if I look down there, then one of the things I might see is my CO is low. If my CO2 is low, then I've got an excess of bicarb. Why would my CO be low? My CO2 be low? Hyperventilation. Hyperventilation. Who was that caused by? The respiratory system. If I have a relative excess of base, what's that called? That's this respiratory alkalosis, secondary to hypoventilation. Okay, so that's how you find that, right? Is to say, use your ABG to diagnose what's going on with the patient with regard to asthma. Okay, expect to see hypoventilation. You know what? They've got this wrong. This should say hyper, right? They should say absolutely hyperventilation. I got this from a Medscape, matter of fact. Somebody write Medscape and tell them they should have hyperventilation is what causes respiratory alkalosis. Maybe they'll give you a recognition or something like that. Who knows? All right, so hyperventilation is respiratory alkalosis. Hypoventilation is respiratory acidosis. Okay, let's make sure there's no questions here before I move on. Okay, no deal. Something else you can check for that asthmatic patient, eosinophils. Eosinophils, okay? The reasoning there, guys, is that eosinophils play a role in asthma, right? If you find more than 4% of all the cells are made up of eosinophils, that actually helps to diagnose asthma if the patient happens to be undiagnosed. Okay, so not only eosinophils, but while we're here, let's hit a couple of other cells. I'm just going to write E for the one we just checked off. Mast cells. Mast cells are something you want to look for in your blood labs. And the reason is when an asthma attack kicks off, what happens is these mast cells come over and they are waiting for something called IgG. I'm sorry, not G, it's E, echo, IgE. With asthma, IgE immunoglobulins, these are antibodies, these IgEs come over and bind to the mast cells. That causes the mast cells to put out histamine and other things. Okay, what did we just say? You can check for higher levels of eosinophils, higher levels of mast cells, higher levels of IgE. So speaking of the IgE, so total serum IgE levels greater than 100 international units are frequently observed in patients experiencing the allergic reactions. Okay, now earlier we mentioned, right, there's different kinds of asthma. So this is these IgE are specific to allergic because what you're looking for is really an anaphylactic reaction, right? And if anybody is familiar with the 4 types of hypersensitivity, then you know that one of the ways I teach it is that you memorize type 1, which is what we're talking about here, with the 4 A's. And the reason these 4 A's are important is just because you have increased IgE does not mean that you've had an asthma attack. It means that you've had a type 1 hypersensitivity reaction, which, by the way, is different from actually saying you're allergic to it. So remember, the first A is anaphylaxis, because that's the kind of reaction that we're talking about. And the second A is asthma. That's the specific pathophysiology that we're talking about. The third A is atopic dermatitis, something atopic. In other words, you might get hives or, right? There'll be some kind of skin manifestation of what's going on. Okay, let me see if there's a question here. Yes, all of these that I just mentioned, right? All of these will present with increased levels of IgE, right? Which is the point of this little spiel right here, is that just because you find the high IgE does not mean that you have that you just suffered an asthma attack. And one moment, I see another question here. Okay, now I answered that one. All right. All right, so we've done that slide. Now, so back up here. Okay, so those are those are probably the highest yielding blood labs that you can get for asthma. There is a uh, experimental lab that you can use. It's a blood measurement called Percolin, but I was not able to find anyone that is to say Quest Diagnostics or LabCorp. I couldn't find anyone actually offering it right now because it's so experimental. It's got not only a higher sensitivity, but also a higher specificity than any of these we've talked about. But once it becomes available, then I will make sure you guys can find it. Yes, there are other non-blood labs that you can order. And I shouldn't say labs. There are other measurements that you can take, right? You can do the pulmonary function testing. But remember with that, as we said earlier, you can expect for those numbers to identify a mixed condition of a little bit obstructive and a little bit restrictive disorder. Can you cure asthma? Yeah, that word cure. You can cure diabetes. Can you cure asthma? There are some medications being developed that will interfere with the whole asthma pathway, like to actually disable the pathway. So I'm going to answer your question by saying there are drugs that won't allow your body to have an asthma attack. I resist calling that cure because it also means that there's things that your body can't do that it's supposed to do, right? So there are drugs that block prostaglandins in the pathway, is an example. But you need prostaglandins for your kidney. So I'm not convinced that doing that is altogether wise. Okay, good deal. Well, if there are no more questions, guys, those are your labs for asthma. You've done it one more time, wasted a perfectly good half hour with me talking about asthma. If you got any questions, just shoot us an email or the telephone number. And other than that, I will see you next week. Have a great week out there. Bye-bye.